Hello, and welcome to Back to the Science. I'm Dr. Susan Oliver, and I'm a scientist, and this is Cindy Oliver, and she's a dog. Just when you thought he couldn't sink any lower, Dr. John Campbell has shown that he is capable of so much more. Yes, I'm talking about his Midazolam video. I could say more at the moment, but I think I'll just let John speak for himself.
The widespread and persistent use of midazolam in the UK suggests a possible policy of systemic euthanasia. Now, these are not my words, these are direct from the paper. You may think they're rather strong words, but we'll see it's based on very good graphical evidence that I'm about to give you. This really is a massive piece of news.
Yes, you heard that right. John is essentially accusing his former colleagues of murder. As a lot of you would know, John used to work as a nurse. He's basically saying that the people he worked with every day have colluded together to murder large numbers of people. Now, a lot of people like to defend John, but what's more likely? The doctors and nurses in the UK all decided to become homicidal maniacs, or John Campbell is making false claims. Anyway, let's see what prompted this latest outburst from him.
Here we have this paper here. This is what we're going to be looking at. So the paper is entitled Excess Deaths in the United Kingdom, Midazolam and Euthanasia in the COVID-19 Pandemic. This is the link. Medical and Clinical Research. This is the journal. And just to give you the citation for this, is really important material. Midazolam and Euthanasia in the COVID-19 Pandemic, and it's published in Medical and Clinical Research, peer-reviewed journal article. Check it out for yourself.
Ooh, a peer-reviewed journal. Let's have a look at that journal. Well, according to the blurb, it is an internationally reputed open access journal that has an impressive impact factor of 2.93. For anyone who doesn't know, that's not an impressive impact factor. Back when I was working in research, my boss wouldn't even let us submit to a journal that had an impact factor below 4. That's not to say that there is anything inherently wrong with having a low impact factor. And in fact, depending on the field you're in, it could be quite common. But a low impact factor is not something that you brag about. They also list various places where the journal is indexed. What's missing from that list is the 3 places that a serious medical journal should be listed. That is Scopus, Web of Science, and PubMed. In other words, it is not recognised as a medical journal anywhere that counts. And hilariously, the journal's email address is a Gmail address. Now, there's nothing wrong with having a Gmail address. I've got a Gmail address, and I'm sure a lot of you listening will also have one. But generally, a proper medical journal will have their own email server. They won't be using a Gmail address. This is not a serious journal. It's what's known as a pay-to-play journal. For a sum of $3,916, you can get your article published by them. Oh, and one more thing, the article only has one author who is an investment analyst. Of course, none of this is a reason to reject what the paper is saying. We should still assess it on its merits. Let's do that now.
Now, this is UK monthly new COVID cases. So new COVID cases here in green, and monthly new COVID deaths, all in thousands, of course. So what we're looking at here, So look at this line here. So this is the level of COVID here. And this is the level of deaths. Now, if this is accurate, this gives an infection fatality rate of 24.3%. And we know that COVID is nothing like as deadly as that. These people seem to be mostly dying, or correlates with the administration of Midazolam. Again, monthly new COVID deaths in red here, and monthly new cases relatively low. And here we see monthly new cases here, but monthly new COVID deaths being remarkably low. Infection fatality rate of only 0.18. So we see clear and strong correlations between excess deaths in 2020 and very low levels of COVID infections at the time when Midazolam was being given out, with less caution than I would like to have seen.
Well, to start with, the figures aren't infection fatality rates. They are case fatality rates. The number of COVID infections, particularly at the start of the pandemic, was unknown because only limited testing was done in the general population. Here's a video that was recorded on the 18th of April 2020, where a kindly gentleman explains this.
The bottom line is many more people might be infected than we think. Now, this is a study in New York City, so we can only talk definitively about New York City. So what it means is there might be many more people infected in New York City than we had thought were infected. And that's also true for other places. I mean, we know that's true for my country, for example, for the United Kingdom. So many places have many more infected people than they realise they have. They might suspect they've got them, but the number of people that are tested positive are actually a minority of the total number that are infected because so many people aren't tested.
And as for the reason that the case fatality rate was so much lower during the Omicron waves in late 2021 and early 2022, it's because the majority of the population was vaccinated then. And contrary to the claims made by antivaxxers like John, vaccination greatly reduces your chances of dying from COVID. More on that later.
Now, this is now the lead time here seems to be about 5 months. This is monthly COVID injections here, and this is the excess mortality. So if we take these two peaks here, so these are monthly COVID injections, and then 5 months later, there's a peak in excess deaths, and again we can correlate the excess deaths with the COVID injections. Doesn't mean to say it's causal, of course, but this merits an answer. The correlations are accurate.
Oh dear, John really needs to try to understand papers before he presents them. The paper's author has already adjusted the data in the figure to account for the 5-month lag, and he found that there is still no correlation. I will just read out what he wrote in the paper. There were clear positive correlations in selected periods, e.g. first half of 2022, but the whole data set without selection bias shows a negative correlation of minus 12%. But the relationship is not statistically significant with a p-value of 0.587. Therefore, the causal relationship observed in Australia of COVID injections being sources of harm cannot be similarly established for UK. On the other hand, these data also show no indication that vaccination had any beneficial effects on UK excess deaths. Needless to say, the claims he is making about a causal relationship being observed in Australia is absolute bollocks. The author is making the classic mistake of assuming a correlation must be causation, like assuming ice cream causes shark attacks because ice cream sales are correlated with shark attacks. Except worse, because there was a 5-month lag in the correlation. The reason excess mortality was seen in Australia was because we opened our borders and let COVID in to run wild. This led to a number of COVID deaths as well as deaths from post-COVID sequelae. However, we know that these deaths were primarily in those who were unvaccinated because it has been studied. In this study here, they compared the COVID mortality rate in those over 50 who were vaccinated and those who weren't vaccinated in New South Wales, Australia. And for those of you who don't know, New South Wales is the most populous state of Australia, and it just happens to be the state where I live. And Cindy lives there too. Don't you, Cindy? The results are shown in this chart here. The purple line, that's purple there, up the top shows the COVID death rate in those who had no doses of the vaccine. The black line below it shows the death rate in those who only had one dose. And the Johnson & Johnson vaccine wasn't available in Australia, so there were no one-dose options for people. The red and blue lines at the bottom show the death rate for those who had 2 or 3 or more doses. As is very clear from the chart, the death rate was highest in those who had no doses. And it was also considerably higher in those who only had one dose compared to those who had 2 or more doses. So yes, there was an increase in excess deaths after the vaccine rollout, but the deaths were primarily in those who were unvaccinated.
UK, England, monthly Midazolam injections and deaths. Now here we see the Midazolam injections in green and we see the excess deaths in red, in thousands of course. So the lead time there, so we see the great increase in the amount of Midazolam given in green, followed by the deaths very closely after that in red. We see it there very clearly. We see it here very clearly. The deaths slightly after the Midazolam increase. Again, we see it here. Again, we see it here. But there is a very tight correlation. Now, of course, patients may be on Midazolam for a few days before they stop breathing. So it's not surprising there's some delay. And prescriptions aren't always given straight away either. But that correlation there is very, very tight indeed.
When John says the deaths occurred slightly after Midazolam prescriptions, that's not really correct. There was actually a lag of 1 month. And if his claims of euthanasia are correct, why would patients be given Midazolam for a few days? If GPs were really wanting to euthanize their patients, surely they would be giving them a large overdose all at once. But they weren't doing that because there was no euthanasia. Medical professionals were doing what they always do, limit pain and distress in their patients. Now, he also mentions that prescriptions aren't always given right away. This is in fact correct. When terminal patients are approaching their end of life, it is common for GPs to use what is known as anticipatory prescribing. And this is not a new thing. Anticipatory prescribing refers to prescribing palliative care drugs in advance so that prompt symptom relief is available at whatever time the patient develops distressing symptoms. But just to be very clear, this type of prescribing is only for terminal patients, and it makes no sense whatsoever that it could be responsible for the 1 month lag in deaths following Midazolam prescriptions. The author of the paper also provides another possible reason for the 1 month lag. He claims it could be owing to delays in death registrations. This is also patently false. The Office for National Statistics specifically analyses delays in death registrations. For 2020, 75.2% of deaths were in fact registered within 1 week of the death, and 89.1% were registered within 2 weeks. And when we look at deaths due to COVID-19, we see that 86.5% of them were registered within 1 week. So this also doesn't explain the 1 month lag. Of course, if there was a correlation between midazolam prescriptions and excess deaths, this would hardly be earth-shattering. Midazolam is recognised as a key palliative care medication needed to ensure quality care in dying patients. So it's hardly surprising that prescriptions of it will increase if there are more people who are dying. The whole premise of the paper and John's video is as absurd as it is abhorrent. In fact, midazolam is considered one of 4 essential drugs needed for quality care in the dying. The others are morphine, haloperidol, and an antimuscarinic drug, of which there are several. Interestingly, if we look at prescriptions of haloperidol, we see that they also increased at the same time as the midazolam prescriptions, as did prescriptions of antimuscarinic drugs. It's curious that John and the paper's author are singling out midazolam and not discussing these other 2 drugs whose prescriptions also correlate a month in advance with excess mortality. We don't see any obvious increase when we look at morphine or when we look at opioid analgesics in general, but it must be remembered that overall prescriptions of opioid analgesics are much higher, so you'd be less likely to see the increase.
If anyone says to you that those two peaks there are not worthy of investigation, how much tighter does it have to be worthy of investigation? They are very close indeed.
Okay, then let's investigate. The first important thing to note with the midazolam prescriptions is that the data is only for GP prescriptions. It does not include hospital prescriptions. Neither the paper's author nor John has mentioned this, perhaps because they don't realise. But this is a very critical point because it means that any deaths that occurred in hospital couldn't possibly be linked to these prescriptions, and any correlation is either spurious or both are correlated to another factor. Like, for instance, toilet paper sales. Now, I don't have the data, but I suspect if you checked, you could possibly also find that excess mortality during the pandemic is correlated with household toilet paper sales, particularly during the first wave, but I am thinking it's probably not the cause either. Anyway, let's have a look at where most deaths occurred. This paper here looked at where deaths occurred up until the 30th of June 2020. And what they found was very interesting. Firstly, 2/3 of COVID deaths did occur in hospitals. So straight away, we know that the excess deaths can't possibly be linked to the GP's prescriptions of midazolam. What is more interesting, however, is that there was a deficit in non-COVID mortality in hospitals that peaked in April 2020. These deaths instead occurred at home and in care homes, as hospitals became overrun with COVID patients. Although it's believed that some of the non-COVID deaths in care homes were undiagnosed COVID deaths, as COVID testing was minimal at this time. This switch away from hospital deaths for terminal patients would explain, however, why more prescriptions were being written for Midazolam and other palliative care medications. People who would normally have passed away in hospitals and therefore didn't require GP prescriptions were passing away at home and therefore did require GP prescriptions. As for what was happening in the hospitals where the majority of COVID deaths did occur, well, neither John nor the author of the paper have a clue because they weren't there. But a large number of doctors, nurses, and other healthcare professionals were there, and they saw how deadly COVID can be firsthand. One of these people was Dr. Jonathan Howard, who was working at a hospital in New York when the pandemic hit. And just picking up on that, the fact that a lot of the doctors who were making these claims didn't actually see any COVID patients themselves or experience the horrors of the pandemic. You unfortunately did, and you devoted a whole chapter in your book to this, which is chapter 2, everyone, if you want to buy the book. Would you like just to, I guess, sort of tell us exactly what it was like working during the pandemic?
Yeah, so I think here in New York City, we got hit first, at least in the United States, and we got hit the hardest. 3 years ago at this time, anyone who worked in a hospital was surrounded by COVID, and nothing but COVID. I saw more patients die in April and May 2020 than I had my entire career. And I saw, dozens of others as sick as could be, but survived. Some of them had been intubated for many months. I saw some young people die. The youngest person I saw die was 23, and that really left an impression on me because it showed that, occasionally the virus could, kill young, healthy people. Looking back on the whole thing, I actually don't think we had it the hardest in New York City. I think every doctor and nurse and healthcare worker in almost all parts of the world experienced some of these scenes at some point. After the summer of 2020, New York City, we were actually never hit very hard again. And we all of our patients were unlucky. Elsewhere, they were misinformed, and we were treated as heroes here. I don't know if we really deserved it, but people sent us cards, people sent us food, they clapped for us, which was nice. And elsewhere, doctors and nurses were attacked by angry, paranoid, misinformed patients, and I never experienced that. So I don't think that I had it harder here in New York City. But what my experience taught me, I hope, is to gain a little bit of humility for what this virus was capable of. When it was allowed to spread out of control, it overwhelmed us, and there were giant trucks behind my hospital to store the dead bodies. Every 5 minutes, the code blue, someone needing to be intubated, team pager went off. When usually it goes off, maybe once per day. I don't know. It was just an entirely different time. Pediatricians were treating children. That's normal. Pediatricians were treating adults, and gynecologists were treating men. So it was just a very horrible time, and no one who worked here will ever forget it.
And I will provide a link to my whole video with Dr. Howard in the video's description, as well as a link to his book, We Want Them Infected, which looks at a lot of misinformation surrounding the pandemic. So, in summary, medical professionals in the UK and around the world did their absolute best for their patients during the pandemic. But COVID can be a deadly disease, particularly in those who are unvaccinated. Providing palliative care and ensuring that people can pass peacefully and not in pain and distress is something that all compassionate medical professionals support. trying to twist this vital care into something else just to get views from anti-vaxxers is simply disgraceful. If you'd like to look further into the data I presented, I provided links in the video's description. And please remember, this video is about the science, but you shouldn't take it as medical advice. For that, you should speak to your medical practitioner. If you've got this far, thank you for listening. And if you've liked, shared, or commented on the video, double thank you, because that helps the algorithm and means that more people will see the video. And of course, thank you to everyone who has bought me a coffee or little sleepy Cindy here a treat. We really appreciate your support. We will be continuing to make videos about the science in the future. So if you'd like to join the cool kids and stay informed, please hit the subscribe button. Thank you.